Okay, so I think we can now start. My name is Marco Nieva. I'm the CSO of the Children's Tumor Foundation Europe, and I want to welcome everyone today to this masterclass in NF1 Dermatological Manifestations, which will be held by three prominent nephrologists in Europe. We are going to introduce themselves now one by one, starting with Pierre.
Hello, good afternoon. Thank you, Marco. I am Pierre Wolkenstein, a professor of dermatology. I'm heading the Department of Dermatology in Henri Mondor Hospital in Créteil, Paris, Greater Region. And I am also coordinating the Referral Center for Neurofibromatosis in France, CERNF. So I'm going to share my screen.
No, hold on, Pierre. We thought maybe everyone introduces themselves first.
Okay, so Laura, can you introduce yourself, and then Circu?
Good afternoon, everyone. So my name is Laura Fertita. I'm also a dermatologist, and I work in the Department of Dermatology in Créteil with Professor Wolkenstein, CERNF, so for the Referral Center of Neurofibromatosis. And my clinical practice, as well as my research, focuses on NF1 and especially on cutaneous neurofibromas.
And you are also Francis Collins Scholarship.
Yes.
And Circu?
Yes, hello. I'm Sirkku Peltonen. I'm professor of dermatology at the moment in both University of Gothenburg in Sweden and in University of Helsinki in Finland. And I have been working on neurofibromatosis for a long time, especially on cutaneous neurofibromas, and most recently in epidemiology. Thank you.
So just before we start, I need to give some instructions to the audience. If you have questions, please use the Q&A box to put your questions in. And after the class, we will have a Q&A session. I also want to make sure everyone understands that this masterclass is directed to medical professionals. Everybody is, of course, welcome to attend them, but we apologize to those who are not medical professionals for the technicalities, but we do invite them to stay, of course, and we will try to answer your questions as well. So I leave the floor now to Pierre to start the masterclass. Thank you.
So can you hear me well? It's okay. So I will start with an update on the diagnostic criteria for neurofibromatosis that are the results of a conference consensus in New York. It was now more than 3 years ago. And this is an opportunity to update you, of course, but also to introduce what are the cutaneous manifestations and their interest in neurofibromatosis type 1 and in its differential diagnosis. So in this slide, you see some sentences that are in black, and the blue part of these sentences are the change that we made during this consensus. So I will not detail them because it's not the purpose of this presentation, but you see that in the revised NF1 criteria, as well as in the previous one, at least 2 or 3 were cutaneous symptoms. Of course, café au lait spots that will be detailed by Circu, as well as freckling in the axillary and inguinal region, 2 or more neurofibromas of any type, or 1 plexiform neurofibroma. And Laura Fertita will discuss this point in the next presentation. So you need to have 2 of these criteria in order to make a diagnosis of neurofibromatosis type 1. One more detail, we introduce, and that is probably the revolutionary criterion, the presence of a mutation in the NF1 gene. That is quite normal. It is now the rule for the vast majority of autosomal dominant disorders. Oops. In this consensus, because Legius syndrome was a differential diagnosis for neurofibromatosis 1, we also managed to build this criteria. For Legius syndrome, you need 2 or more of the following manifestation, 5 or more café spots bilaterally distribute, and no other NF1 related diagnostic criteria except for axillary or inguinal freckling. Of course, again, a mutation, but here in the SPRED1 gene, that is, of course, the gene that is the gene of Legius syndrome. And of course, it's an autosomal dominant disorder. And if you have one parent that is with Legius syndrome, it will be one more criterion. We introduce also, and that is very important for you, a definition for genetic mosaicism. So you see that there is a possibility to have a kind of distribution of NF1 symptoms and again, dermatological manifestations in a segmental way or in a mosaic way. That is a result of a post-zygotic mutation that will lead first to a first hit and then to a second hit that will be distributed along a segmental area, and that will make the diagnostic or the diagnosis of genetic mosaicism. So to also introduce in the literature the fact that we need also to have criteria for mosaic NF1, we have the listing of the criteria here. So here the pathogenic heterozygous variant is not 50% of the cell in the unaffected tissue, but is less than 50%. You need also to have the same in 2 different areas, and you need, of course, to have a clearly segmental distribution of café spot or neurofibroma. And you need also to exclude the fact that one of the 2 parents should fulfill the diagnostic of criteria for NF1. So it's very important to see that, again, we introduce a strict definition, a new dogma in the field of neurofibromatosis type 1. For Legius syndrome, it is exactly the same, but the fact that the distribution will not distribute neurofibromas that are not a symptom of Legius syndrome, but only a segmental distribution of café spot. And again, a distribution of SPRED1 variant that will follow the rules of mosaicism. So here is the distribution of on this slide of several cutaneous manifestations and the main diagnostic criteria for NF1. Cutaneous neurofibroma that will be discussed by Laura, freckling that will be discussed by Sirku, again a large café spots that will be discussed also by Sirku, and leash nodules, and a family tree of an autosomal disorder. So why, in fact, we managed to have these new criteria? So just a challenge for you. It's a case report, a young girl that is followed up, if I will remember, by Sirku. She is 8 years old. She has freckling. She has café spot, and is it SPRED1? I remind you that SPRED1 was introduced as the cause of neurofibromatosis 1-like phenotype more than 15 years ago. And you see here the guy with a blue shirt with a tie is Eric Legius. So the difference between Legius syndrome and neurofibromatosis type 1 is clearly the absence of cutaneous neurofibromas. So in this case, Is it neurofibromatosis 1 or Legius? What will help you to make the diagnosis? First, and that will be detailed by Circu, the presence of juvenile xanthogranuloma is more an argument for neurofibromatosis type 1. Again, the presence of nevus anemicus is probably also a strong argument for neurofibromatosis type 1. It is present in 50% of patients with NF1 versus 2% in controls. So now I will give the speech and the voice to Laura, and I will stop sharing my screen.
Thank you very much. You all see my screen? Yes?
Yes, beautiful screen.
I will now talk about the cutaneous and subcutaneous neurofibromas related to NF1. So this is the classical classification for neurofibromas. You have 4 types described of neurofibromas. The first one is the cutaneous neurofibroma, which is an exophytic tumor moving with the skin on examination. The second type is the subcutaneous neurofibromas. These type of neurofibroma lie deeper in the skin and do not move with it. They are firm to palpation. Internal or deep neurofibromas involve any nerve anywhere along its length and are not palpated. And plexiform neurofibromas involve multiple fascicles and branches and extend into surrounding structures. These are pictures of cutaneous, subcutaneous, and plexiform neurofibromas. And we will start with cutaneous ones. You will see here a panel of pictures representing all types, size, shape of cutaneous neurofibromas and according to different phototypes. So you can see how they can be different in their presentation. As Professor Wittgenstein just said, they fall in the diagnostic criteria updated in 2021. They generally develop during puberty and affect the vast majority of patients, more than 90% of individuals with NF1. As I said, their distribution, shape, number, size can vary among a same patient and among different members of a single family. And the constant is that their number increases throughout life. These tumors are benign tumors. Different shapes exist for this kind of neurofibromas, starting with flat, sessile, globular, peduncular. There is not a constant evolution in these 4 steps of shape, but all types can be present in a single patient and in a single area. You will see here the scars, a post-operative scar after a CO2 laser therapy. Concerning the pathology of cutaneous neurofibromas, these tumors are composed of different cellular components, mainly Schwann cells, but also fibroblasts, macrophages, mast cells, and blood vessels, in all a collagenous matrix within the dermis. These tumors have an impact on daily life. First, they can induce pruritus or pain. They also are considered as one of the highest burdens in the NF1 population because they can be responsible for major change in body image perception and could have also a negative impact on quality of life. It has been demonstrated that their higher total number and their facial distribution correlate with the poor CNF-related quality of life. To date, there is no medical treatment to cure or even to prevent their development. Only interventional procedures are available, such as surgery or electrodesiccation or CO2 laser therapy. But these techniques are not always accessible to the majority of the global population and can often result in aesthetic scarring. So clinical and preclinical trials are ongoing and more expected in the next years. You can see here the scarring evolution after CO2 laser therapy. So just after the intervention, and after 6 months, and you can see here at 1 year after the intervention. So you can see that this can help patients, but is not the perfect solution to treat CNF. Now, subcutaneous neurofibromas. So just to compare, as I just said, the skin upon the neurofibroma is completely normal, and you can only palpate the cutaneous under the neurofibroma under the skin. These types of neurofibromas also fall in the diagnostic criteria and also generally develop during puberty. As I just said, they are under the skin, but it is possible to have a secondary cutaneous involvement. For example, it is possible to have a subcutaneous neurofibroma with a cutaneous ones upon the first one. They are firm to palpation, and they can be painful. So the neurofibroma, subcutaneous neurofibroma, involve the subcutaneous tissue and the skin in some cases, and these types of neurofibroma comprise the same cellular components of those described in CNF, but with a diffuse growth pattern specifically in these types of neurofibroma. It has been demonstrated that subcutaneous neurofibromas are independently associated with mortality, and it has been also shown that malignant peripheral nerve sheath tumors are the main cause of death in young patients, especially. So these MPNST can be spontaneous or can result from the malignant transformation of an existing neurofibroma with the supposed sequence neurofibroma, dysplastic neurofibroma, or also another name is NUBP, which are pre-malignant precursor towards MPNST, so the malignant transformation. It has been demonstrated that a number of at least 10 subcutaneous neurofibromas is associated with internal neurofibromas. And internal neurofibromas, as I said, that they have a potential of malignant transformation and has to be followed. These different information led to the definition of an at-risk phenotype of developing MPNST in NF1 patients. So the definition includes at least one internal NF and or at least 10 subcutaneous neurofibroma present to define this phenotype. In our center, we implemented a targeted screening strategy using the whole-body FDG PET MRI for all adult patients presenting an at-risk phenotype. The aim would be to detect early MPNST and or its pre-malignant precursors. And so when their diagnosis of either kind of tumors is verified by radio-gated biopsy, they are systematically removed when accessible. This strategy should allow the early diagnosis and treatment of MPNST and its precursor, but also lower the risk of radiation exposure using the MRI imaging rather than the tomodensitometry. So this is the screening strategy we currently use in our center. So using the whole-body PET MRI, when some features are present, such as a softmax more than 4.5 and or diffusion restriction anomalies described in simultaneous multi-slice diffusion weighted imaging in the MRI part of the PET MRI, there is a suspicion of MPNST. And in these cases, after multidisciplinary meetings, we decide to radio-guided biopsy this lesion or to monitor it. In practice, we collected the information of our daily practice for this strategy. And from July 2017 to June 2019, we performed 162 imaging exams in our center, representing 140 asymptomatic patients, including 106 with an at-risk phenotype, so 76%. And overall, this imaging 8 MPNST and 29 pre-malignant precursor were diagnosed in 31 patients, and all but one we had an at-risk phenotype. The question then was, is there a sampling bias when targeting the most hypermetabolic area to perform the radio-guided biopsy? And the answer would be no, because in our result, we showed that pathological diagnosis was confirmed in 96% of precursor cases and in 100% of the MPNST after the surgery. Thank you very much. And then I will pass to Sirku.
Thank you, Laura. I will now talk about other skin manifestations of NF1 other than neurofibromas. I have no conflicts of interests to declare. Pigmented melanocytic lesions are the most common manifestation, and I will talk about those, and then two additional signs to support NF1 diagnosis, which Pierre already mentioned, juvenile xanthogranulomas and nevus anemicus. Café au lait macules and freckles are the local melanocyte-derived lesions, and in addition to that, many patients with neurofibromatosis have a little bit darker grayish brown general skin color, which is also associated with NF. Café au lait macules are the important diagnostic sign of NF1, and for diagnosis you need 6 or more café au lait spots. Typical café au laits have quite sharp borders, and you could actually use pen and circulate those so it's so sharp. But they are totally macular so that you can't palpate them. They should be bilateral. Otherwise, if they are only on one side of the body, you should suspect a mosaic NF1. Café au lait macules are caused by the second hit in the NF1 gene in melanocytes. In dark, more hyperpigmented skin, the café au lait macules are again a little bit darker than skin in general. They may be present at birth, but it's more common that they appear during the first months of life, and by the end of the first year, the child usually has developed at least 6 café au lait spots if the child has neurofibromatosis. On the other hand, they may start to disappear at middle age, and many older persons with NF1 tell that they used to have more café au laits, and actually you may not see any café au laits when the person is over 60 years. These pictures show a few atypical café au lait spots with not so sharp or smooth border. This on the left hand side is called coastline of Maine border. One typical phenomenon is also a huge café au lait spot which has darker pigment spots inside the café au lait. There may also be melanocytic nevi in the area. Axillar freckles are also very typical for NF1. Normally, you don't get sun-induced pigment spots in the axillae, but in NF1, they start to develop around age of 4, and they are the same color as café au lait macules. It's common that patient or the parents of a child may not have noticed them, So you have to remember to take a look if you are making diagnosis. So it's possible that they are present at birth, but usually they appear by the school age. And it's been shown that about 80% of 4-year-old children already have at least some freckles. They appear slowly, so that at first there may be just a few ones, and then the number increases by time. And the freckles may become more widespread during childhood and adolescence. And some individuals with NF1 have very widespread freckling all over the body or around the axillary and inguinal area. Women also may have freckles under breasts. These pigment changes in NF1 can be explained by the NF1 gene function. NF1 gene regulates the activity of melanin production. NF1 mutations lead to overactivation of RAS pathway, and they also lead to inactivated cyclic AMP levels. And both RAS pathway and cyclic AMP levels upregulate important genes in melanin production. And that leads to local hyperpigmentation and in general hyperpigmentation. You may sometimes see unusual pigment changes, and it may be a sign of an underlying plexiform neurofibroma. So if you see something like on the left-hand side spots on one side of the neck and shoulder area, that was a sign of underlying plexiform tumor in plexus area. And on the left-hand side, right-hand side, there is a child with a plexiform in the arm. Juvenile xanthogranulomas are yellowish or orange, white flat papules, which are very typical in color and can be, especially are common in small children. If one takes biopsy, which is not recommended because you can recognize these clinically, but in biopsy, if you ask pathologist, it shows an accumulation of non-Langerhans cells, histiocytes, and xanthoma cells and Guyan cells. The most common sites for juvenile xanthogranulomas are head and neck, and the number can vary between a few to even 20 to 30. They are predominant in infancy, and they usually appear during the first year of life and then slowly start disappearing, and by teenage years they are not visible anymore. Nevus anemicus is a pale spot or group of pale spots which may not be visible unless the surrounding skin for some reason becomes a little bit reddish. For example, if you are scratching the skin, or if there is hot weather, or the child has taken a hot bath, or in Finland you have been in sauna. So you can see that these spots stay pale. They may not be easy to find, so the patient or the parents usually know if there are such an area. And they are caused by permanent vasoconstriction. And as Pierre told, they may be present even in half of the individuals with NF1. But underdiagnosis is likely because they are so difficult to notice. Both Nevus anemicus and juvenile xanthogranulomas are nice and useful diagnostic tips if you are wondering if the child has NF or not, but they were not included in diagnostic criteria, mainly because the diagnostic difficulty. One word about NF1 and wound healing. There is no evidence to show that NF1 would affect wound healing, so it's safe to do operations that are planned for NF patient. And another word about itch. It's also common that especially areas with small neurofibromas, they may itch, but many individuals with NF1 itch also without tumors being the cause. And that's the reason for that is not known. And unfortunately, we don't have any good cure for that. Thank you for your attention.
I thank all the presenters for their contribution. Pierre has disappeared from the screen. I suppose he will join back in, I hope. We have 2 questions from the audience already. I invite everyone to start putting their questions in the Q&A box. The first question is from Darinka Ivic, and she asks, what are the endocrinological manifestations of NF? If one of you 2 would like to answer this question.
I might start by answering that some people have if there's an optic pathway glioma close to chiasma, that may cause, for example, puberty that starts earlier than normal. That and also pheochromocytomas, which are tumors of adrenal glands, can cause endocrine problems.
Yeah, welcome back. Maybe you want to add on to this answer. We have Darinka, who wonders whether there are endocrinological manifestations of NF besides the ones that Sirku just
yes, I agree. We are having the experience of pheochromocytoma. That's my only experience of neuroendocrine tumors. In fact, in extreme case, you can have necrosis of the digit of the fingers and the toes. That is sometimes a sign for dermatologists of a tumor. And in the context of a neurofibromatosis type 1, you need to think about secreting a pheochromocytoma.
Maybe I can add the metabolic syndrome, which is not endocrinological speaking exactly, but can be related because as we talked about the vascular anomalies in this patient, we also know that they are more at risk to develop cardiovascular diseases. So it is not related or directly associated, but it necessitates a monitoring in these patients.
Just maybe a detail that is not a detail from me because it's my experience. When you have a global deficiency in the axis of after radiotherapy for an optic glioma with a total requirement of substitution, hormonal substitution, these patients have less neurofibromas as if hormones were necessary to develop neurofibromas at adult age, but it was never published. But in my experience, this type of patients have less neurofibromas if they are in insufficiency in hypopituitarism.
Thank you. We have another question from Federica Chiara in Italy. You mentioned the presence of macrophages in cutaneous neurofibromas and mast cells. She'd be interested to know the activation status of these macrophages, M1 versus M2, in human tissues, and whether they are also present in plexiforms and UBP, which are the atypical plexiforms.
That is a topic of Circu.
Yes, I would like just to comment that we have a paper which is under review investigating this. So there are both M1 and M2 macrophages, but M2 seem to dominate in cutaneous neurofibromas, but that's unpublished data at the moment.
And that's not why you have mastocytes, that you have an efficiency of antihistaminic drugs. That is also something that could be a question.
Another question from Luciana Ganosa. How often are the imaging studies performed to rule out the PNST? This was actually a question I had for Laura as well. How often do the patients, undergo this MRI procedure?
This is a really interesting question. For now, our strategy is based on first imaging, so using this PET MRI when they first come in our consultation. I am not talking about the symptomatic patients, of course, which who will be investigated because they have either a pain or neurological deficit. But concerning the asymptomatic patients, that will have first these imaging in our center if they correspond to an at-risk phenotype, so showing more than 10 cutaneous neurofibromas and or at least one internal neurofibroma. And then, so if there is any anomalies or suspicion of transformation, these lesions will be biopsied and or removed surgically. But if not, this is a grand question. If there is internal neurofibromas which necessitate monitoring, we usually discuss to have a control of this imaging at 1 year, but this is always the subject of discussion in multidisciplinary meetings. And if the imaging is perfectly normal with no internal, we do not systematically perform a second imaging. At least we have new symptoms, but if not, we do not systematically perform an imaging monitoring for these patients.
I think this is a very interesting study that you're carrying out. There are attempts, here and there, everywhere in the world regarding how to predict the transformation. And I was wondering, if do you have enough patients enrolling so that it can become, it could actually become, a standard. You could actually decide in the end if it can become a standard.
That's exactly what we were talking about, because since then we have the result I just showed you. So it's more daily practice exposition of our result, but to have the final result, we should demonstrate that we have a reduction of morbidity, so of malignant transformation and augmentation of survey. So till now, and since we have started this strategy in 2017, we do not have enough time since the beginning of our strategy to predict, but this is what we think, but we do not have the numbers yet.
So to add some details, I think that we have the correct number, but the follow-up is too short today to say that we will gain in mortality. But the global I would say impression is that we increase the number of dysplastic neurofibromas that we manage to remove, and therefore probably indirectly we can hope that we will reduce the mortality. We have a paper that is ready to be reviewed. We will submit it probably in the week, but this paper will not show a gain in mortality. So today, again, we need time to know if this strategy is only there to collect more dysplastic neurofibromas or to decrease the mortality, because the decrease of the mass will lead to a decrease of risk of transformation and to a decrease of mortality.
Thank you. A question from Scarlett Parada. Do cutaneous neurofibromas also appear in the pubic region or just in the inguinal region?
Everywhere.
Short answer.
Yes.
Maybe Scarlett, maybe if you want to ask another question to maybe there was something else that was meant behind this question, please type it in to the Q&A box. A question from Maggie Seblani. Has there been any impact on the reduction in cutaneous neurofibromas in your experience in patients who have been treated with a MEK inhibitor?
That is a good question.
NF1 related conditions such as low-grade gliomas and inoperable plexiform neurofibromas.
So clearly, I saw pictures of some patients that were treated in a trial with MEK inhibitors, with selumetinib to tell the generic name, and there is we have some results. It's results that are from the center of Birmingham, Alabama. So the proof of concept of the decrease of the size of cutaneous tumors of cutaneous neurofibroma is done. But is it sufficient to decrease totally the cutaneous neurofibromas? I am not sure, and I will tell Laura to complete the answer. And again, you have the balance between side effects and the hope of reduction of cutaneous neurofibromas. If you have 20% of the patients that have cutaneous side effect for benign tumors, it's not something that could be approved for this kind of tumors, because we need in dermatology to have very, very safe drugs. That is the issue. But maybe Laura, you can complete, and Sirku maybe.
Yes, in our experience, because we treated already some patients with MEK inhibitor for plexiform neurofibromas, and we did not see any difference in shrinking the tumors. And recently, and these results will be soon published, we demonstrated that in the mouse model, so we are not talking about human NF1, but in mice model, the MEK inhibition induced a prevention on the development of new cutaneous neurofibromas, but does not shrink the tumor already in place. So these results have to be taken with precaution, because we all saw pictures of patients with reduction in size of this tumor under MEK inhibition, but we have to perform further analysis to,
Yeah, I have no experience on follow-up of patients with MEK inhibitors, so I can't tell more.
So to be clear, the results today on mice models are more in favor of a prevention before the appearance of cutaneous neurofibromas than really in place neurofibromas. But we do not have biomarkers to know which patient will have plenty of, or which patient will have a few. So if you imagine, for example, a population of 100 people, that 80% will have a few and 20% will have a lot, you will treat 80% of the population preventively for nothing. So we need really to improve biomarkers of prediction and to improve what we want to have as a strategy, prevention or curative treatment. That is the challenge of the next 10 years.
Federica Chiara actually asked a question related to this. She said, besides the potential effect on cutaneous following treatment with a MEK inhibitor, has anyone evaluated drug delivery into the tumor itself?
You mean drug concentration in the tumor? If this is your
No,
question?
drug delivery.
The question
Topical, for example.
Yeah, topical.
So there is a trial, two trials that are ongoing. One is quite finished from a topical MEK inhibitor that is promoted by a firm that is NF1. And it appears that I did not see the results, but a shrinkage is claimed. So really, a topical delivery of a MEK inhibitor on site could be an option. But again, it's more treatment for prevention than a treatment for to cure.
Federica asks also if you think that collagen interferes with the drug delivery at all.
I don't know for the result of NF1 because, but coming back to the mice model, we performed a preclinical trial using topical MEK inhibition. And so the result that I was just referring to concerning the prevention of the development of tumors was not inhibited by collagen, but again, it was prevention strategy, and the treatment didn't work on already in place cutaneous neurofibroma. So this could be an hypothesis.
But if we imagine another way to inject or to have a kind of vehicle that is not a cream, it's possible to imagine that we will have a delivery of the drug on site. But again, and I will ask Sirku to comment on that. The vast majority of the neurofibroma, it's collagen, it's fibrosis. So it's something that you cannot reduce. You can act on Schwann cells, but you cannot act on fibrosis.
Yeah, and that's most likely because the MEK inhibitors don't shrink the tumors, but you might be able to prevent, because collagen is very stable protein. So it like scars, they don't disappear easily. The collagen stays there.
You can imagine to have a small decrease because you are acting on the Schwann cells, but the part that is collagen will not be targeted by the MEK inhibition.
Yes.
Federica clarifies that she was thinking of collagenases.
I don't think we know.
In the past 10 years ago, some teams tried to destroy the collagen, but with an efficiency that is not today clearly established. So I dream to have something to remove the collagen, but I do not have that.
A question, now we're moving out of this theme, and a question from Sarah Van Dyke about the diagnostic criteria. What do you advise on when there are only a few less than 5 neurofibromas histologically confirmed and no other criteria? Do you always perform additional research, or does it depend on the age of the individual, the wish for children, and other factors?
So I think that there is two different questions: the question of strategy and the question of science. Today, the strategy of the department is to offer at each patient that is under the age of 18, because there is, besides the parental project or the wish to have children that will be there one day or not, to offer the possibility of having the identification of the mutation in the NF1 gene, that it is a strategy. For science, or for the diagnostic or diagnosis of a child, the policy today is different between sporadic cases and familial cases. If you have a familial case, one of the two parents has neurofibromatosis type 1. If you have a few neurofibroma, you got the diagnosis. So it's not necessary to confirm with the research for mutation. When you have a sporadic case with only café spots, it can be Legius, it can be neurofibromatosis type 1. There, you can differentiate the two syndromes, the two diseases, and the follow-up will not be the same. But it's again a question of strategy, and I'm very curious to know what is the strategy of Circu.
Yes, she's asking about neurofibromas, and it's not very unusual that older persons, let's say over 60 years old, develop a few neurofibromas. And I think it's important to see if they are on one side of the body or one skin area. That points towards mosaic or segmental development of neurofibromas. And I have seen quite a few older persons with 5 neurofibromas, but without anything else and without no anamnesis of no history of café au lait spots. And if they are older, they already have adult children who are healthy, then I wouldn't do anything. But if it's a question of a young person, it's totally different. Then I might recommend gene test. Mutation analysis.
Then we have a question from Melanie Deval, who says that in plexiform, the laser treatment is common, but can have lower response rates. But what is your experience?
No, laser surgery, and we published with Circu recently a paper which offer, I would say, the state of the art of the possibility of laser. As told by Laura, you will have scars, so it's not a perfect treatment. And this treatment is for cutaneous neurofibromas less than 1 centimeter. Otherwise, you will have a large scar and a healing that will last for weeks. But concerning plexiform neurofibromas, in my experience, and I'm not omniscience, but clearly laser is not an option for plexiform neurofibromas.
And I have never tried removing hair from plexiform neurofibromas. I think that's what she's asking about. But have you experience on that?
Yes, we have I have experience of depilation of to remove hair on café au lait spots and on plexiform neurofibromas. It is working, but it's depends on the difference of the color of the hair and the color of the skin, because it's easier when the difference between the color of the hair and the color of the skin is really a gap.
And the last question from Amarada, what is your opinion? What are the gaps and the unmet needs when it comes to NF1 dermatological manifestations?
My answer is clear, will be clear. We need to end cutaneous neurofibromas. And again, my wish during the last part of my career is to see a treatment, and clearly a preventive treatment for the appearance of cutaneous neurofibromas. Here is, in my opinion, the unmet need.
I completely agree.
Yeah, I share this opinion too.
And until we find a treatment, what is the best thing that we can do?
I think that clearly, again, we need to help patients in removing what is possible to remove. A cutaneous neurofibroma that is more than 1 centimeter of diameter could be removed by dermatological surgery. It's not too difficult. And all the techniques of destruction And for us, it's laser surgery in first are an option to help patients. But again, it's not the golden standard because you will have scars. So a patient will not have a clean skin. They will have a skin with scars. You saw the scars that are hypochromic showed by Laura. It's not perfect. So it's today the option that is quite good for patients that would like to improve their quality of life. But Sirku, maybe you can complete.
Yes, I agree. And there will be a study which colleagues from Denmark will present in CTF meeting where we have tested HIFU ultrasound, highly focused ultrasound, and that may be better answer because it doesn't cause scarring, but it's still in study phase.
Laura?
I totally agree with what you said. And for now, we just have these treatment interventional procedures that are not sufficient for patients. And I think that thinking about a topical treatment would be at least on the topography that are the subject of this impact on daily life. This would be a first step, yes, in preventing the cutaneous neurofibromas.
I don't think we have still a bit more time, but no questions coming up. So unless there is something that you feel you haven't answered thoroughly, you'd like to deepen on?
No, I think that we covered the field, and we were very happy to have a lot of registered participants. That is quite a sign that the target of the skin is probably an unmet need and also expected by patients and professionals.
Absolutely. Well, I thank you. I thank you, the three of you, for your good talks and for answering all the questions so thoroughly. I thank the audience for being very, very participative today. This webinar is being recorded right from the start, and it will be posted on the YouTube channel as soon as technically feasible. And as soon as technically feasible, it would also be translated in the usual languages for most nationalities to watch. Thank you, everyone. We will be updating the website with new masterclasses in the coming month or two. And I look forward to seeing all of you again at the next round. Thank you.
Thank you very much.
Thank you.
Bye-bye.